Doctors, Assalamu alaikum. Let's read about atrial fibrillation, a very basic introduction from past medicine for the MRCP preparation. Okay, let's jump into it. Atrial fibrillation, AF, is the most common sustained cardiac arrhythmia. Most common sustained cardiac arrhythmia. It is very common, being present in around 5% of patients over aged 70 to 75 years and 10% of patients aged 80 to 85 years. Whilst 70 to 75 years, okay. Whilst uncontrolled atrial fibrillation can result in symptomatic palpitation, and inefficient cardiac function. Probably the most important aspect of managing patients with AF is reducing the increased risk of stroke, which is present in these patients. Types of atrial fibrillation. Atrial fibrillation may be classified as either first detected episode or paroxysmal episode or persistent or permanent. First detected episode, paroxysmal, persistent or permanent. First detected, paroxysmal, persistent and permanent. So, what is the first detected episode? Irrespective of whether it is symptomatic or self-terminating. First detected episode, recurrent episodes. When a patient has two or more episodes of atrial fibrillation, if episodes of atrial fibrillation terminates spontaneously, then the term paroxysmal atrial fibrillation. When a patient has two or more episodes of AF, if episodes of AF terminate spontaneously, then the term paroxysmal AF is used. Such episodes last less than 7 days. Paroxysmal come and goes, two or more episodes, and episodes terminate spontaneously, and typically less than 24 hours. If the arrhythmia is not self-terminating, then the term persistent. Self-terminate and not terminating. If it self-terminate, paroxysmal. Benign positional paroxysmal vertigo. Come and goes, resolve, paroxysmal. But if it doesn't resolve, then persistent. Persistent AF. If it doesn't terminate, then it's persistent. Paroxysmal, persistent. Such episodes usually last greater than 7 days. Episode lasts greater than 7 days. In permanent AF, there is continuous atrial fibrillation which cannot be cardioverted, or if attempts to do so are deemed inappropriate. Permanent cardioverted, no. Treatment goals are therefore rate control and an anticoagulation if appropriate. Rate control and anticoagulation. So, first detected episode, just one time. Then paroxysmal, it comes and resolves. Persistent, it lasts for more than 7 days. Maybe permanent, no cardioverted, rate controlled, and anticoagulant. Okay, what are the symptoms and signs? Symptoms: palpitation, dyspnea, chest pain. The signs: an irregular pulse. Investigation and ECG is essential to make the diagnosis, as other conditions can give an irregular pulse, such as ventricular ectopics or sinus arrhythmia. What is it? An ECG is essential to make the diagnosis, as other conditions can give an irregular. Okay. Management: rate and rhythm control and reducing the stroke risk. One, there are two key parts of managing the patients with AF. Number one, rate oblique rhythm control. Rate oblique rhythm control and reducing the stroke risk. Stroke risk we need to reduce. Rate versus rhythm control. There are two main strategies employed in dealing with the arrhythmia element of atrial fibrillation. Two main strategies. Rate control. Rate control means accept that the pulse will be irregular. The pulse will be irregular, but slow the rate down to avoid negative effects on cardiac function. Rate will be you need to accept it that the pulse will be irregular, but slow the rate down. The rhythm control try to get the patient back into and maintain normal sinus rhythm. This is termed cardioversion. Drugs, pharmacological cardioversion. Oh, sorry. Cardioversion. Drugs and synchronized DC electric shock may be used for this purpose. Drugs, that means pharmacological cardioversion, and synchronized DC electrical shocks, that means electrical cardioversion. So cardioversion, pharmacological cardioversion, electrical cardioversion may be used for this to rhythm control. For many years, the predominant approach was to try to maintain a patient in sinus rhythm. This approach changed in the early 2000s, and now the majority of patients are managed with a rate control strategy. NICE advocates using a rate control strategy, except in a number of specific situations such as coexistent heart failure, first onset AF, or where there is an obvious reversible cause. Rate control. Rate versus rhythm control. Now, rate control, a beta blocker or a rate limiting calcium beta blocker or rate limiting calcium channel blocker like diltiazem is used first line to control the rate. If one drug does not control the rate adequately, NICE recommend combination therapy with any two of the following: beta blocker with diltiazem, digoxin. Any two. If one drug does not control, we can use any two: beta blocker or diltiazem, or beta blocker digoxin, or digoxin with diltiazem, or digoxin with the beta blocker. Yes. And rhythm control now. As mentioned above, there are a subgroup of patients for whom a rhythm control strategy should be tried first. Other patients may have had a rate control strategy initially but switch to rhythm control if symptoms or heart rate fails to settle. So, other patients, I mentioned above, there are subgroup of patients for whom rhythm control strategy should be tried first. Rhythm control need to be tried first. Other patients may have had a rate control strategy initially, but switch to rhythm control if symptoms or heart rate fails to. If we try rate control, but if it doesn't work, we need to work on rhythm control. When considering cardioversion, rhythm control is cardioversion. It is very important to remember that the moment a patient switches from AF to sinus rhythm presents the highest risk for embolism leading to stroke. Imagine the thrombus formed in a fibrillating atrium suddenly being pushed out when sinus rhythm is restored. For this reason, patients must either have had a short duration of symptoms, less than 48 hours, or be anticoagulated for a period of time prior to attempting cardioversion, reducing stroke risk. So how can I control rhythm control? How can I control the rhythm? Drug cardioversion, or DC cardioversion, electrical cardioversion. Rhythm control, to control rhythm control in cardioversion. Rate control is just a beta blocker. Okay, now reducing stroke risk. Some patients with AF are at a very low risk of stroke, whilst others are at a very significant, some less, some very high risk. Clinicians use risk stratifying tools such as the CHA2, DS2, BASC, CHA2, BASC. This could determine the most appropriate anticoagulation strategy. C means congestive heart failure 0.1, H hypertension or treated hypertension 0.1. If age, A2 means age more than 75 years 0.2, age 65 to 74 years 0.1, D diabetes 0.1, S2 prior stroke, TIA or thromboembolism 0.2, V vascular disease including ischemic heart disease or peripheral arterial disease 0.1, sex female 0.1. That there are another table shows a suggested anticoagulation strategy based on the score. Score 1, no treatment needed. Score 1, male, consider anticoagulation. Female, no treatment. This is because their score of 1 is only reached due to their gender. 2 or more offer anticoagulation. Okay, NICE recommend that we offer patient a choice of anticoagulation, including warfarin and the novel oral anticoagulants, direct oral anticoagulants. So what we have learned, in AF there are 4 types. Okay. Number one is first detected, then paroxysmal, persistent, or permanent. The main target of our management is to control the rate, to control the rhythm, and reduce the stroke. So rate control, just medicine, beta blocker, all rate controlling calcium channel blocker, diltiazem, or digoxin. And in rhythm control, to control the rhythm, there are drug cardioversion or electrical cardioversion. To reduce the stroke, there are CH2, DS2, VASC criteria, that thing to start anticoagulation. Thank you.